Well, guys, we'll go ahead and get started. It's right at the hour. And so we are just so tickled to have you all with us today as we join this fourth webinar in our 6-part series on post-COVID patient transitions. It's our subject today. The webinar is being recorded and will be posted to our website, and Caleb Lewinsky is working on that, and he will be sending the recording and slides to the participants at the end of the series. So I'm Kim Mayo. I am a program specialist with the DRCHSD program, which is providing this webinar today. The DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. So before we get started with today's webinar, I want to let you know about what's coming. So of course, today we have the post-COVID transitions. And then for the next, we have 2 more after today on next Thursday, same time, industry-based telehealth programs. And then to wrap it all up at March 25th, we will be talking about analytics to measure telehealth outcomes. Again, we just welcome you to today's webinar. We do encourage any questions or discussion. We all have worked together and for a while, and some of us know each other very well. So we welcome you to unmute and ask any questions. You can please type in the chat box. Please find that chat box and type in there. And when you're not speaking, we do ask that you keep yourself on mute. But again, I want you to find that chat box. And if you haven't already, please fill in your name and your title and your organization. That really just does help us to just know who's here joining us today. So now I'd like to introduce our speakers today. We have no stranger to this webinar, of course. If you've been here once, you've seen them, Donna McHale and Jessica Duke. Donna has over 30 years of experience in the healthcare industry, and she is a leader in Huron's healthcare technology services. And Jessica has over 16 years of experience in healthcare industry, and she's a registered nurse with extensive experience in patient care management, process improvement, and telehealth. We're fortunate enough to have 2 great guest speakers with us today, Julie O'Shaughnessy and Debbie Dexter, and they'll be joining us just a little bit later. So to start things off, I'll turn things over to Donna.
Thank you, Kim, and welcome everybody to our 4th session. Wow, they're coming fast and furious. So today we're going to walk you through some post-COVID transitions. So we have some really cool things queued up for you today. So we'll go into some of our objectives, and then Jess will talk about some of the post-COVID rural care issues. And then she'll also talk a little bit about hybrid telehealth programs, because this is something that we see a lot of organizations trying to figure out what that right balance is. And then Julie O'Shaughnessy is going to talk to us about resilience. So what is it and why does it matter? And then we have Debbie Dexter coming to us with the COVID effect on rural healthcare. So some really interesting aspects there. Then Kim will lead us through a panel discussion, and then I'll give you some things to take away with. Next, please. Caleb? Oh, sorry. So then the learning objectives are, we're going to learn about the rural healthcare trends for post-COVID. And then, as I said earlier, learn a little bit about this hybrid. What is a hybrid approach, and why is it important, and what are some things to consider with that? And then Julie's topic about resilience. I think you'll really enjoy that a lot. We do. And then this is the area where Debbie's going to talk to us about really understanding what's going on with behavioral health, the market trends, the access, the impact of COVID has had within behavioral health, and then how to consider moving forward the best way. And then to network and make new connections and have fun. So next, please. So as we have questions, or as you have questions, feel free to use the chat box, or just raise your hand within chat, or come off mute and just give us your question. So all of them will work easily for us. So next, please. Now I'm going to turn it over to Jess. Jessica, you're on.
Awesome. Thanks, Donna. So wanted to give some references in thinking about post-COVID, particularly in the rural healthcare space. In a report, February 25th, from the American Hospital Association, they said that in 2021, hospitals will lose about $53 to $122 billion in revenue. This is in year 2021. They also stated that in year 2020, $323 billion was lost in revenue. So when we think about this, and I know this is really a difficult subject to kind of talk about, they're thinking that more than 450 hospitals in the rural space are at risk at closing, and that 200 of those hospitals are considered high risk. 46% of hospitals of the rural hospitals are currently operating in the red. And so their services are disappearing in the rural areas. They're struggling to provide operational and financial resources to the communities. Good news is there's about $500 million that they're looking to award from the Department of Agriculture to rural hospitals for additional COVID relief. And these funds they're anticipating awarding could be used for expenses, particularly for distributing vaccines and for telehealth. So that's some positive note. Now, on the negative side, the predictions for post-COVID rural healthcare, they think that patients' financial profiles are definitely going to deteriorate. They're struggling. The reduced market size is definitely in the foreseeable future. They think that healthcare delivery is definitely evolving, and that's where that telehealth is coming into play to deliver additional services. There is a higher marginal cost of care. We're going to see that in the future. And the community health status is definitely worsening. So let's go to the next slide. Now, in a survey done by Amwell about physician and consumers and where they're looking for healthcare is towards telehealth, 92% of providers said they expect to continue video visits, even when it's okay to convert back to in-person visits. They like what was happening. And if you look to the graph, it's my left, it would be maybe your right, but they said that 94% are okay with doing the prescription referrals, and that's for a provider. And 93% of providers are okay with the chronic care check-in. And then the consumers also were okay with continuing that thought process. And there was a shift with primary care providers also doing scheduled visits. In the physician experience, they were also, 80% of them were okay with continuing with that telehealth encounter. And I thought this was really interesting. So 1 in 4 patients are looking for a provider that can provide back telehealth services and are willing to switch to a provider that can provide telehealth. So they want a good mix on this. So Caleb, let's go to the next slide. So my question back to you guys is, what does post-COVID look like for your organization? Are you changing your care models? Have you adapted in any way? If you'll go down to the chat box or come off mute, let's have a discussion about this.
Jessica, this is Lisa in Madison.
Yes, ma'am.
For our community here, I think it's just really opened a lot of eyes to like what is possible, and that telehealth is really not something to be afraid of, and it's something that we can all utilize better and more. So I think it just kind of really pushed a lot of people, including some of our staff, into using telehealth and trying it out. So I think it'll be a good thing in the future to promote growth actually for us.
That's awesome. So Lisa, you're talking expanding your market?
Yes, and just really raising patient convenience options.
Yeah.
Because you all know how busy we are all in our lives between work and home, and just, you know, being able to get a sick child in for an antibiotic that just needs a quick visit. It just makes it that much easier for patients and their families.
Absolutely. Convenience is a huge component of this. So Rachel in the chat box said increasing the amount of clinics within our organization who use the telehealth to reach our patients. So it's putting the telehealth in additional clinics. Doug Tanner said there is little interest in our market with teleprimary care. However, our focus is to use telemedicine as a platform to bring heretofore available specialist care to our community and facilities. So you want to drive in the specialists is what I'm getting from this. So that's some great feedback. I'm really excited to see what all can happen, particularly post-COVID, because like Lisa said, it's opened up the conversation. Patients aren't as afraid of it anymore. So I think that's kind of where the post-COVID is shifting. Does somebody else have something to say? Okay, so we'll go to next slide. So like Donna alluded to, is the hybrid telehealth program. We're seeing this a lot of our clients and a lot of organizations. They're trying to find a balance between the inpatient and telehealth. I know when we worked with Dan in his ambulatory practice, that's one thing that they're working towards, deciding what patients can be seen by telehealth and what patients should not be seen. So the benefits to the patient, like Lisa alluded to, is the convenient factor. So you're improving overall satisfaction through that convenience. You can adapt to working hours and school hours and improving that communication with the provider and accessibility to a specialist. The benefit to the provider is you have a decreased no-show rate, maybe improved cost of care, maybe less transfer rates because they have more access to their primary care for those easy visits, and then improve provider satisfaction. The satisfaction for the health system could be those decreased unnecessary ED visits or readmission rates, and then they improve satisfaction back to the patient, and improve care team alignment utilizing that telehealth program. The technology available is going to be the same that we've talked about prior to. You could do it through a two-way audio. You could even do an asynchronous with just a using an application that you're going to triage the patient through, like a Storm Forward platform, or you could even do a phone call. So lots of different technology that you could utilize for this hybrid modeling. The barriers are still the same. Unfortunately, does the patient have technology? Do you have the technology in your office space? Digital literacy continues to be a technology issue. And then language for interpretation, and then the patients that do have hearing impairment or vision impairments. So that's kind of the hybrid model, is finding that balance between who can be seen by telehealth and who's just not the right patient. So we'll go next slide, Caleb. I'm going to turn it over to you, Kip, so you can introduce our next speaker.
Awesome. Well, we are super excited. And Jess, I just want to make sure you saw that comment from Greg there as well. You're looking at that. Well, we are super excited to have Julie O'Shaughnessy here with us. She has within 30 years of hands-on industry experience. She is passionate about helping healthcare organizations and leaders improve workforce well-being and engagement. Julie serves on the team responsible for guiding physician and provider organizations to improve their importance. During her 17 years with Huron, she has worked with a wide range of clients, including large systems and independent medical groups, with a focus on improving physician alignment and engagement to improve provider well-being and ease of practice. Prior to joining Huron, she served in quality management, business development, and performance improvement leadership roles at several hospitals and health systems. So Julie, it's your turn. Thanks for being with us.
Thank you, Kim. I'm excited to be with the group today. I do want to start with Caleb, if you can flip to my first slide, since I'm going to talk about resilience, and I know the topic today is transitions. Jessica and Donna felt like it would be helpful to just talk about not only your patient transitions, but also your workforce transitions. So I'm going to focus on workforce well-being and engagement, of which resilience is a key part of that. Do want to start by defining resilience. And we use a definition of it being the ability to bounce back, not only as an individual, but also as a work team and also as an organization. There are so many things that are the result of our DNA that we do not have the ability to change. The good news is that as individuals and organizations, we can learn and develop personal traits for resilience. So Caleb, if you can go to the next slide. Just wanted to talk about why this is important and why it matters. This slide just lists a bunch of facts around workforce resilience and certainly creates the business case for why it's important. I always look at it from the standpoint of, as leaders, we all have a responsibility for creating the best work environment for our employees so that they can provide exceptional care to the patients and communities that we serve. And this is a very telling slide, just in terms of the impact, not only of the pandemic, but just the pressures that our workforce faces, and also what they may continue to face as we move into our post-COVID mode of operating. So if you can go to the next slide, please. This just shares some interesting statistics about just the impact of the pandemic. And I think we're at that 1 year mark. I think I'm seeing a lot of things. I know I personally took my last airline trip a year ago today. So, but just again, the impact of the pandemic in terms of the number of healthcare workers reporting distress, and also the decline in mental health since the pandemic began. So if you can move on to the next slide, there's been a heavy emphasis over the past year just on organizations helping to support their workforce, our employees, through personal and individual resilience strategies. Our model that we use at Huron actually reflects ultimate well-being is impacted by both organizational factors and then the workplace team factors. And our model really looks at building a resilient organization that you have to address a lot of factors that are listed on this slide. So if you can go to slide 6, please. As I shared earlier, individuals can develop personal traits for resilience. There's also research published in the Harvard Business Review that says that same is true, that organizations can develop resilient cultures. So on the next slide, I just highlighted some of the characteristics of a resilient culture. And when we have conversations with organizations on this topic, they say, we do all of those things, but I'll challenge you to think about how well do you do each of those things. And the one I really want to emphasize is the efficiency of the work environment. And as Kim said in my opening, I am particular to physician engagement or provider engagement. And that's because I used to be one of those quote unquote suits that used to stand outside the patient room or the exam room and hound my physicians and advanced practice providers, asking them to help me with the administrative work. And then one day I started to follow them into the room when they were talking to the patients and saw what they were dealing with. So I kind of said, I have a bigger responsibility here beyond just doing my administrative work, but also creating the best environment for my providers to practice. And what we see in here, unfortunately, is a lot of organizations, when they try to become more efficient, put more burden on the frontline providers to do tasks that may be more efficiently done by others, just to streamline the process. And that can definitely have an impact, not only on the personal resilience of that individual, but also the team resilience. And then also just looking at the organizational performance. So if you can move on to the next slide, please. Our approach when we look at resilience is to really start with getting an understanding of the current levels of workforce well-being. And we use it, we do an assessment on this, and it's different than what you typically see if you're measuring engagement and alignment. So if you can go to the next slide, Cal, it really focuses in on what are the individual traits and motivators of the people that make up your workforce, which is very different than asking if they would recommend your organization as a place to work. You really get a better understanding of what the different segments are in your population. And once you know the individual motivators and traits of the people in your workforce, you then can develop a very individualized strategy in terms of how to create that culture of resilience. If you go to the next slide, this is just an example of the outcome of our analysis, and you'll see that there's, and I apologize that it's so small, I have to shift over and look at my bigger monitor, but you'll see we look at the workforce in terms of different segments. So in this organization, 17% of the workforce is independent drivers, 14% are first movers, 25% are lifestyle optimizers. And each of those segments have characteristics. And again, you can look at that at both the organization and the department level, and then you're developing your strategies that appeal to the motivators for each of those groups. So it's much more telling and rich in terms of the information that it provides in terms of the environment that you're creating for your team to practice. You can go on to the next slide, please. So I know this is very brief. I did want to close with this quote, and I firmly believe this, and this is actually work that was pioneered by the American Medical Association, that we do have an obligation as leaders to take a system-wide approach to focus on resilience and workforce well-being. And, you know, I know that's what you're all committed to every day, because it's the systems that create some of the challenges and frustrations that when our healthcare workers show up to work that chip away at their resilience. So again, big advocate for taking a systems approach and really focusing on the cultural aspects. So with that, I think I'm turning it over to Kim. So thank you for your time.
Thank you, Julie. We appreciate that so much. And we're excited to welcome, just one second here. Here we go. To welcome Debbie with us today, Debbie Dexter. She is an experienced healthcare executive with more than 30 years in the industry. She joined the Able2 team in early 2019, responsible for growing the business through new client partnerships. Prior to joining Able2, Debbie spent 10 years with Regents Blue Shield, 17 years at Aetna, and 2 years at a startup focused on alcohol use disorder. She's no stranger to behavioral health, having launched Able2 as a pilot in 2010 for her jumbo national account client at Aetna. Debbie lives in the Seattle area and spends her downtime traveling and exploring other countries and cultures. And I'm ready to get there with you, Debbie. So
yeah, can't wait to do that again, right?
That's right. Thanks for being with us today, and I'll turn it over to you.
Yeah, it's my pleasure. If you go to the next slide, I thought it would be helpful to take a look. Prior to COVID, you know, there was tremendous demand for behavioral health needs in the market. You know, 1 in 5 adults experience a mental health need in any given year. And those adults with chronic medical conditions, it's really 1 in 4 have a behavioral health need. And, you know, sadly, less than, 60% of the population is not getting any help at all around those behavioral health needs. We also know there's plenty of data out there that shows when somebody's got, untreated mental health issues, and when it's coupled with medical conditions, their medical spend can be up to 4 times more than a mentally healthy individual, which really is just costing our system, our health system, our employer populations tremendous amounts of money. If you go to the next slide, this gives you a nice snapshot of what we saw midway through the pandemic in 2020. We saw more than 50% of adults reporting an impact on their mental health, significant increases in stress and anxiety. That 1 in 5 number is now greater than 1 in 3 people expressing symptoms of anxiety and depressive disorder, which is significant. And the reality is we have seen pretty significant spikes in the use of alcohol and other substances to sort of self-medicate during this pandemic. And it's just, it's a lot. We know that then, and I have another slide that'll speak to this, but we know that there are long-lasting effects from situations like this pandemic. And that's something we're gonna have to face over the next several years. So if you go to the next slide, one of the main, telehealth has increased access for behavioral health care, and certainly through 2020, the stigma has been reduced in terms of people acknowledging that they need help. They're feeling extremely anxious and depressed and isolated, but cost continues to be a significant barrier. It actually is the #1 barrier for people seeking behavioral health care services. In a study that was conducted by Mercer, 1 in 5 patients would actually choose medication and physical health treatment over mental health issues. And they just have to prioritize it that way. And cost is a tremendous barrier. If you go to the next slide, this slide really does speak to the statement I made earlier in terms of the long-lasting effect that natural disasters, traumatic events, environmental, all of those things, the long-lasting effect it has on our mental health and behavioral health needs over time. This past year has been an extraordinary one in that we weren't just dealing with a global pandemic, but there was tremendous social unrest. It was a highly political year in terms of separating and divisiveness across the country, which has just exasperated the demand. You can see with some of the historical facts around, the impacts of these types of large scale issues. When 9/11 happened, 1 in 10 of adults in New York City showed major depressive disorder. 25% increase in alcohol use, which is fairly consistent with what we saw throughout 2020. And then even when Hurricane Ike hit in 2008, there was a significant impact on the population in terms of that major depressive disorder. In 2006, there was a study that was conducted on the psychological impact of the 2003 SARS outbreak. And this really allowed, they looked at the impact of first responders, frontline workers. And again, you see, fairly significant high levels of post-traumatic stress disorder. You see up to 3 times more likely for those people who were on the front line, who were impacted by that SARS outbreak, really having post-traumatic stress symptoms, which is significant. And then the long-lasting impact of that is those conditions will be remaining for the next 2 to 5 years. So, it's not over just because we're in a new year, that the demand on healthcare and behavioral healthcare needs is going to continue. So if you go to the next slide. So it wasn't all bad news in 2020. We did see some loosening of regulatory requirements that allowed improved access for populations. We saw waiving of cost share for telehealth visits, even across Medicare and Medicaid plans, across commercial plans, which increased access. We did see increases in reimbursement rates. So where historically telehealth visits were paid at a lower level, we saw parity in that payment and reimbursement for telehealth visits versus in-person visits. We'd like to see those remain because there's some disparity in the reimbursement rates overall. We saw some loosening of the licensure requirements, whereby providers are required to be licensed in the states in which they're delivering care. We saw some of those regulations come down. Unfortunately, there was some ambiguity in those requirements, which created some problems down the road. But we'd like to see some of those bureaucratic requirements stay loosened so that we can provide cross-licensure support. And then we saw loosening in the requirements around audio and visual. So there, especially in the CMS regulations, there's requirements around an in-person visit first before they'll reimburse for a telehealth visit. We saw that loosen. Where video was a requirement, we saw that move to audio only so that people were comfortable and had greater ability to connect via telephone versus the video component. So we'd like to see some of these things remain in place. Through the CARES Act, we've seen support throughout 2021 for some of these things and some of the cost share waivers. So more to come, but it remains a focus of the legislature and the providers as a whole. If we go to the next slide. I saw something in the chat around concerns around new entrants like Walmart Health and others who are, bringing really cheap telehealth visits to the table. Throughout 2020, we saw a surge of new entrants in the digital and virtual telehealth space around behavioral health care. And then it really raises a number of concerns around the quality of the care that's being provided and the regulatory environment around making sure that it's high quality evidence-based care and it's not doing harm. It's not just providing access to a number of services, but really providing access to high quality care so that people truly are getting the help they need. Let's go to the next one. We see continued evolution in terms of the traditional sources for behavioral health care support. EAPs continue to exist while utilization still remains extremely low. We've seen employers increase free visits for therapy through the EAP from 3 free visits to 6 free visits. We've seen EAP vendors trying to bring in more telehealth type services or partner around that to help address things. But EAP still remains a lower utilized service. We've seen the behavioral health carve-outs. We've seen some consolidation of that with Anthem buying Beacon and Centene buying Magellan. But those models really looking to innovate and really help proactively identify potential people in need and reach out to them, all the while bringing televisits to the forefront to be able to provide greater access. And we see employers really focusing on providing telehealth coverage, both on the medical side as well as the mental health side. In 2019, there was an increase in that. We saw a doubling of that in 2020 as they really tried to support their employee populations and their family members. And what has been a continued theme even over the years is that there's very little appetite for these single point solutions anymore. Both health plans and employers are looking more for solutions that can provide more of an end-to-end suite of solutions across the spectrum and complexity of need versus just single point solutions. If we go to the next slide. This one speaks to how behavioral health care has been evolving over time through the onslaught of new virtual and digital providers in the behavioral health space. You know, those were really designed to address access. So even your teledocs and your Amwells have on-demand access to virtual behavioral health therapy. But what's really important and what we're really starting to see people ask questions about is not just access to services, but access to quality care that then has the ability to deliver outcomes data so that we know people are getting better. So when you put those things together, you'll see in the end, they've got sort of a scorecard view, but it's important not to just be addressing access, but as physicians and providers, you know the importance of quality care and being able to demonstrate outcomes data. So that's really where we're starting to see a shift, which is really, I think, is an important shift in our market. Go to the next one. Sadly, mental health providers are not paid well. When mental health visits are paid at a significantly lower rate than medical visits. And then when you move to lower level licensure, so from a psychiatrist, then to a psychologist, then to a licensed clinical social worker, you see even further reductions in the reimbursement rates for those services, even though that's where the predominant access is at like the LCSW level. We've seen a significant decline in psychiatric psychiatrists in medical schools and in entering into practice, and partly because mental health is one of the worst paying degrees in the market today. And as more and more demand continues to be prevalent with so little access, most of the care is now being delivered out of network, which sadly means more out-of-pocket costs for the individual seeking that care. So that gets back to that cost being a barrier. And we've seen the cost really increase about 13 times faster in the mental health space, and largely because of the out-of-pocket expense that they're experiencing from non-network providers, because that's what's predominantly available to them. Let's go to the next slide. We really like what we're seeing in terms of the collaborative care model. Predominantly people in large, especially the older population, seek help first with their primary care physician around mental health needs and behavioral health needs. And we've seen even through the Affordable Care Act, reimbursement for behavioral health screenings at the primary care practice. Unfortunately, a large number of primary care practices then don't have anywhere to send their patients. So they may prescribe a medication, but don't really have a good avenue to direct a patient to quality behavioral health care. And so what we've really started to see across the country are these collaborative care models where they're bringing primary care and behavioral health care resources together to be able to support those patients in the moment and get them the help they need or get them connected to quality behavioral health care services, both virtually and in person. And I'm excited to see that this area of focus continues to grow in different pockets across the country. Let's go to the next one. And this social determinants of health has been a hot topic for a number of years now. And as you all in rural communities know better than anyone, I mean, if you can't get somebody to focus on their physical health and their mental health disorders, if they're focused on housing and food and transportation. And we know that, some of the lowest income bracket males are 3 times more likely to have a mental health disorder compared to males in the highest income bracket. Yet there's very little that, these individuals are not accessing care. We also know that when there are unmet social needs, housing, food, transportation, all of those things, people are 6 times more likely to have poor mental health or mental health needs. And then we know, like from loneliness and isolation, that has the same impact as smoking 15 cigarettes a day. So it's a topic that we've seen more focus on. And as an organization, we've put more focus on to really start to identify where lonely and isolation exists, and then how to address that in the behavioral health interventions to help people get the help they need. And then, again, we're not doing a good job within the physician practices in screening for those social determinants of health, in large part because if you screen for it, then you need to do something about it. And not everybody has the capability or access to services to support patients. So we're really starting to see more and more focus in this area, particularly as we're moving out of pandemic and some of the protections in housing and all of that come down. I think we're going to see a rise in homelessness, which is going to then exacerbate some of these needs in the long run. Let's go to the next slide. And then this really gets me back to the focus on evidence-based care and quality of care. So, even in outpatient behavioral health care services, there's very little insight into the use of standardized assessment tools and the consistency of using evidence-based treatment protocols and guidelines. There's very little outcomes data that inpatient or outpatient therapy visits are expected to deliver back to health plans. And there's very little oversight, unlike on the medical side, where there's a lot of rigor around outcomes data and value-based care. We're starting to see conversations occur around behavioral health moving into that space. And it's something that we should be expecting. And this is a phenomenal stat, but there's over 10,000 mental health apps in the market today. And only 14% of them have any evidence-based design in the care that they're delivering and how protocolized within the mental health apps are. So we really want you to take a step back and ask about the quality of care that's being delivered, the evidence of the application or the digital tool, so that we really can focus on clinically meaningful outcomes for the patients that we're all serving. So let's go to the next slide. This slide, I really like this one because it starts to create a foundation as we're working with other health plan partners or within the provider community, as even large employers, as they're assessing behavioral health solutions, really focusing on some key areas. Again, you're going to hear me talk about quality and value all the time. It's not just about access. It has to be about access to quality care with proven outcomes using standardized assessment tools. And then raising awareness around, helping reduce the cost to eliminate the barrier for care, destigmatizing behavioral health and making it something that we can easily talk about and help people get the help they need. And then looking at innovative solutions whereby, you're looking at partners who are working to collaborate with provider systems and other healthcare systems in a collaborative way to really support the holistic care of an individual. And these are things that are all really important when evaluating behavioral health solutions. Let's go to the next one. So this is just my wrap-up slide that really talks about, as we see increases in behavioral health demand as we slip out of, a global pandemic into somewhat more of a state of normalcy. We know there's going to be some long-lasting effects, but there's hope around the corner now with vaccines. So how do we continue to provide access to behavioral health specialists and other programs, but making sure that there's a balance between technology and human? We know that the human connection is critically important to drive engagement and meaningful behavior change. So while technology has allowed us to deliver care virtually and digitally, the human support versus a chatbot or AI functionality is really, really important. And then really making sure that we're treating behavioral health care with the same rigor that we've been doing for decades on the medical side. We've got centers of excellence around cardiac care and cancer care and hips and joints, but we don't have centers of excellence really around behavioral health care. And we need to establish that and demand it for our patients. And again, high quality care that delivers outcomes data is critically important. So let's go to the next one. Yeah, and that's it. So I'll just open it up to questions or turn it back over to you, Jessica and Kim.
Great.
Next slide.
Yeah, thanks so much for that great presentation. So now is your opportunity as a guest with us to just unmute or to a chance for you to chat, ask any questions or any comments that you may have of this panel of experts. So I'll just open that up to you guys now.
And Caleb, if you could go to the next slide, please. Thank you. These are just some questions that may be thought-provoking, but anything that's come up during the session? You could use the chat area, come off mute. I mean, what have you heard from your providers about the post-COVID transition? Are they looking for some kind of a hybrid model? No telehealth at all? What have you been hearing? Lisa, Dan, you guys are still on. Any insight from your providers?
Donna, why don't we circle back to Gregory's question, or actually statement that was in the chat. Gregory, do you want to come off mute and let's talk to what you had put in the chat?
Sure.
Not to put you on the spot. Sorry about that.
So going back to telehealth and sure. So once COVID-19 has worked its way through the system, which we all are cautiously optimistic it's trending in that direction. We definitely will see an increase in in-person encounters. What was born out of this pandemic, I guess, if there are a few positives, was we partnered with our local EMS, the Washington Ambulance District, to reach out to our patients that were either fearful of coming into the clinic despite social distancing and screenings and other things we'd put in place. There was definitely the fear of going out in public. And it was vital that some of these people see their providers, whether it be an uncontrolled individual with diabetes, somebody with a substance abuse or opioid use disorder, and needing to get their counseling or medication assisted treatment, whatever, we definitely noticed a decline in these visits. So we partnered with the local EMS partner, and they were doing telehealth visits. Nothing fancy. Again, we didn't have fancy equipment. Secured, HIPAA compliant Zoom meetings where they could do store and go with our providers, or synchronous, where they would, hey, Susie Smith's A1C is, 42 and we have definite concerns. Nurse practitioner Jones, what do you think? And then be able to dialogue. It's in its infancy stages, but definitely has caught the attention of Medicaid, of how it's reduced transportation costs of EMS to the EDs of our CA, unnecessary Medicaid visits to our local community access hospital. So it benefits our patients, it benefits us, and it benefits the local CA. So everybody wins, as long as the reimbursement that we're currently receiving remains in place. When it goes back to half of what it was, and we lose revenue from these visits, and it becomes difficult to realistically provide that service, that's when the reevaluation of this will occur. That's really all I had. Thanks.
I think that's great. That's a great use case to understand how you adapted during COVID for particularly a chronic care program. Anybody else have an example of a program that you've had to put together and get creative like that? Man, it's a quiet bunch today. Who else is left on the call? Everybody's dropping off.
Yeah, still have several folks.
Just one more comment. I can't say enough about partnering and communication. The local critical access hospitals have been has always been a godsend. We need our CA. Yes, we have healthy competition with them on the outpatient aspect, and we make that overt. We talk about it. We try not to duplicate. But, I believe, and my colleagues may be on this call, as they're also, as you know, a recipient of the Delta program, which is great. But to keep the EDs and avoid admissions of people that don't really need to be there, so they're available. They're critical access, and they don't have a lot of beds, and they need their beds open right now for COVID cases, certainly, and for the other things that go on in this community: strokes, heart disease, everything that everybody on this call deals with on a daily basis. But, we have chosen as entities to embrace each other because we each have our role. And I know that's certainly the case. And I'm sure for my colleagues on this call, they follow that mantra as well. But I know in many cases, whether it be pride or competition, patient care suffers. I can confidently say that we do have competition, but patient care doesn't suffer.
Yeah. I think that, like you said, there's few positives that have come out of COVID, but I definitely think communication with your surrounding hospitals has opened up in the communication lines. I know Brad's on the line, Brad from Peatneyville. You've extended communication with other surrounding hospitals in Southern Illinois. Any thoughts there? Nobody wants to talk today.
Everybody's quiet today.
Well, Donna, do you think we should go ahead and?
I think we should. We can wrap up. Yeah. So, and Caleb, if you could just, build the screen up for us, please, that'd be great. So there were a lot of really great things that we learned today. We had three very powerful speakers. So a couple of things to keep in mind as you leave this session is that the rural healthcare delivery with the care models, they're just evolving with telehealth. So, and they continue to do that. Post-COVID, it's been interesting to see that consumers are looking for PCPs that provide telehealth, and that the majority of providers are going to continue with video visits post-COVID. And then this is one that we see, and we're working with a lot of organizations on right now, is what is that right balance for the hybrid model, in-person versus telehealth visits? So this is the question du jour. And just as individuals have developed resilience traits, they can develop a culture of resilience. So that we learned from Julie, and I think it's just such a great line to take away. And that successful organizations can focus on being resilient prior to times of crisis or after the crisis develops. So it's really good to kind of look at your resiliency before the crisis hits. And that we pulled a couple of great thoughts to take away from Debbie around patients are choosing to get their treatment for physical health versus mental health due to the cost of care. So that was a big aha, I think, for many of us. And that the traditional health plans and resources continue to evolve. And that there are ways to decrease the rise of behavioral health after COVID. She had that really nice list, the two list and the nice wheel. So lots of great takeaways from today. So Kim, next to you.
Well, thank you all for joining us today. We appreciate you, Jessica, Donna, Julie, and Debbie, for sharing such great information with us. And we thank you all that attended today and watched today's webinar. And we encourage you to come back next week, same time, and as we will talk about industrial-based telehealth. And we're so glad that you joined us all, and we hope that you have a great rest of your day. And we'll see you next week.
Bye-bye.
Bye, everybody.